Okay, let's dive in. Picture this. You've got maybe a stack of notes, trying to get your head around a new topic, or maybe you're revising for something big, and it just feels like information overload. You
Yeah.
need the core stuff, the essentials right now.
Yeah, that's always the challenge, isn't it? Trying to filter out the noise and just grab what you really need to know.
Exactly. And that's what we're here for on the deep dive. You give us the material, like today, your specific revision notes on a really important medical topic, and we really dig into it. We try to pull out the key nuggets, the high-yield facts, make it clearer for your revision, your learning.
Think of it like we're looking over your shoulder at the notes with you, pointing out the absolute must-knows, connecting the dots, maybe helping structure it so it actually sticks.
And today's topic, straight from the notes you've shared, is testicular cancer, which is, well, it's particularly significant given the main age group it affects.
hmm So our plan today is pretty straightforward. We'll walk through these notes you provided step by step, cover the basics, what it is, the causes, or rather the risk factors, how it presents, diagnosis, treatment, the outlook, potential issues down the line, all based entirely on this material.
Great. Let's start right there then. The absolute basics from your notes. What exactly is testicular cancer?
Okay, so the notes define it pretty clearly. It's a malignant tumor, a cancer that starts in the testicles, the male organs responsible for sperm and testosterone production.
And right away, the notes seem to highlight two main types.
That's right. A really key distinction is made between seminomas and non-seminomatous germ cell tumors. You'll often see that shortened to NSGCTs, and this split is crucial because they often behave and are treated a bit differently.
Got it. Seminomas and NSGCTs. Now,
Oh.
something that really jumps out early in your notes. While it's quite rare overall, maybe only 1% of all male cancers.
It's actually the most common cancer found in young men. The notes specify that key age bracket, roughly 15 to 35 years old. That fact alone makes it incredibly important to know about.
Yeah, that's a demographic you really need to remember. And the prognosis. The notes sound quite positive there.
Oh, definitely. Exceptionally positive, actually. The notes state a 5-year survival rate of over 95%. That's huge. It means it's highly treatable, particularly if it's caught early.
Your notes also touch on a broader way to classify them. By cell type, germ cell, sex cord stromal, things like that. But it seems like for practical purposes, for revision, that seminoma versus NSGCT split is the main takeaway highlighted in your material.
Exactly that. That primary division really informs a lot of what comes next, especially in terms of management strategies.
Okay, so causes,
Hmm.
etiology. Your notes mention the exact cause isn't really known, but they point towards genes and environment.
That's the gist of it, yeah. It's not like there's one single trigger. It seems to be more of a mix of underlying genetic predispositions and possibly environmental factors playing a role.
Which brings us neatly to the risk factors. This seems like a really packed section in your notes. What are the absolute headliners, the ones you'd put a star next to?
Well, according to your material, the two biggest ones, the most significant, are cryptorchidism, that's the medical term for an undescended testicle, one that didn't fully drop into the scrotum, and having a family history of testicular cancer. So if your father or brother had it, for instance.
Okay, cryptorchidism and family history. Definitely key takeaways. Why is cryptorchidism such a big deal? Do the notes offer a simple reason?
The notes sort of imply it's about the abnormal environment for the germ cells when the testicle isn't where it's supposed to be in the scrotum. That difference in temperature and development seems to make those cells more likely to turn cancerous later on.
Interesting. And there was a specific gene mentioned, too.
Yeah, TGCT1. Your notes suggest that carrying this particular gene variant can increase the risk quite significantly, something like up to 50 times. Really underlines that genetic link.
Wow, 50 times. Okay. And beyond those big two, your notes list quite a few others. HIV infection, male infertility, even things like having an infantile hernia, Kleinfelter syndrome, low birth weight, tall stature, testicular microlithiasis. It's a varied list.
It is, yeah. It suggests there might be multiple pathways or associations involved, but, based on your material, cryptorchidism and family history are consistently the ones flagged as having the highest impact.
Right. So pathophysiology. How does it actually start and, importantly, spread?
So your notes explain the origin. It starts from abnormal germ cells inside the testicle. These cells begin to divide without control, forming a lump, a tumor.
And if it spreads, Where does it typically go first, according to the notes?
It might stay just in the testicle, but the notes really highlight spread through the lymph system. Specifically, they mention the periaortic lymph nodes. Those are deep in the abdomen, kind of behind the gut. That's the primary drainage spot for the testes. It can also spread through the blood to distant organs, especially the lungs.
And the mechanism underneath all that?
Fundamentally, it's about genetic changes, mutations, that mess up the normal rules of cell growth. Your notes also hint that seminomas and NSGCTs might have slightly different patterns of spread sometimes, which kind of ties into how they present later.
Okay, before we get to symptoms, let's touch on differential diagnosis.
Huh?
Why is this bit so important? Someone finds a lump. It's not automatically cancer, right?
Absolutely not, and that's a crucial point. Thankfully, most testicular lumps aren't cancer. There are several other common conditions that can cause similar symptoms, like swelling or pain. Getting the diagnosis right is obviously vital.
So what are the main mimics listed in your notes, the things doctors need to consider?
The notes list quite a few. Things like epididymitis or orchitis, those are inflammations or infections of the epididymis or the testicle itself. A hydrocele, which is just a collection of fluid around the testicle. A spermatocele, a type of cyst. And testicular torsion, that's where the testicle twists on its cord, cutting off blood supply. That one's a real emergency. Lymphoma is also mentioned as something to consider, although it's less common as a primary testicular lump.
And how do doctors usually tell these apart initially?
Your notes really emphasize the combination of a careful physical examination and imaging studies, specifically an ultrasound scan. Ultrasound is apparently very good at showing whether a lump is actually within the testicle tissue itself, which is suspicious for cancer, or if it's something separate, like fluid outside it.
Right, that makes sense.
Hmm.
Okay, let's look at the numbers, the epidemiology. Your notes seem to focus quite a bit on the UK context.
They do, and it reiterates that key point. It's the most common cancer in UK men aged 15 to 49. So slightly broadening that peak range we mentioned earlier, covering the whole period of highest risk according to the source.
And the rate, how common is it in the UK?
The notes quote about 10 cases per 100,000 males each year. And interestingly, they point out that this rate, the incidence, has actually been going up over the last few decades.
That's definitely something to note. An increasing trend. Makes you wonder why, doesn't it? Better diagnosis, environmental changes.
It's a really good question. The notes don't speculate much, but they state the trend. And alongside that rising incidence, they also repeat the good news. That high cure rate, still over 95%.
What about globally? Do the notes give a wider perspective?
Yeah, globally it's much rarer, maybe 1.5 cases per 100,000 men overall. The peak age is still generally 1540, with the absolute highest rates in the 20-35 group. It's extremely rare in young boys, before 10, though the seminoma type can sometimes occur in older men too.
Any geographical or ethnic patterns mentioned?
Yes, the notes mention it's significantly more common in places like Norway, other developed nations, and less common in developing countries, citing India and Thailand as examples. Again, sort of hints at potential environmental or lifestyle factors interacting with genetics.
Okay, clinical presentation. This is really practical stuff from your notes. What does someone actually notice? What brings them to the doctor?
The absolute number one thing, highlighted right at the top in your material, is a painless lump or swelling in the testicle. Your notes say this is how it presents in over 95% of cases.
Painless. That's so important, isn't it? Because pain often makes people seek help faster.
Exactly. The lack of pain might lead to delay. Other symptoms listed include maybe a feeling of heaviness down there, sometimes testicular pain can be painful, just less common than painless, and occasionally a dull ache in the lower abdomen or groin, like a dragging sensation.
Any other signs the notes mention?
Gynecomastia, that's breast enlargement in men, can happen. Your notes link this to the tumor itself producing a hormone called beta-HCG.
Ah, one of those tumor markers we'll get to. So the tumor is making hormones that affect the rest of the body.
Precisely. That HCG can have effects elsewhere. The notes also make a practical point. Sometimes a recent knock or minor injury might draw attention to the lump during a self-check. Not that the trauma caused it, but it led to discovery. And sometimes a hydrocele, that fluid collection, can be there alongside the tumor, maybe masking it slightly.
What about symptoms if the cancer has spread, if it's metastatic?
Your notes are quite specific here. Back pain could indicate spread to those periaortic lymph nodes in the abdomen common, especially for seminomas. A persistent cough or shortness of breath might suggest it's reached the lungs, which the notes say is maybe more typical for NSGCTs like teratomas. Swelling in the legs could, in advanced cases, mean blockage of major blood vessels. And finding a swollen lymph node, particularly on the left side, just above the collarbone, the supraclavicular region, that's another potential sign of distant spread.
And when the doctor examines the patient, what are they feeling for?
Well, your notes say a distinct lump is almost always palpable. Key things they might feel. The affected testicle often feels heavier, maybe firmer than usual, and it loses that kind of delicate sensation a normal testicle has. Crucially, it's usually not as tender to touch as it would be if it were just inflamed, like an orchitis.
And you mentioned something earlier about the groin lymph nodes, the inguinal ones.
Yeah, it's a bit counterintuitive, but your notes specifically point out that the inguinal lymph nodes, the ones in the groin crease, are unlikely to be enlarged from testicular cancer itself. The reason is the lymphatic drainage pattern of the testicles. It goes upwards, inside the abdomen, bypassing those groin nodes initially. So swollen groin nodes usually point to something else, like a skin infection, not primary testicular cancer spread.
That's a really useful clinical pearl from the notes. Okay, so someone comes in, suspicious lump, examination points towards cancer. What are the key investigations listed in your notes to nail the diagnosis and figure out the extent, the stage?
The pathway outlined in your material usually starts with blood tests, specifically looking for tumor markers. The main ones mentioned are HCG, AFP, and LDH.
Let's quickly break those down based on the notes.
Sure, HCG is human chorionic gonadotropin, a hormone, often associated with pregnancy but also made by some testicular cancers. AFP is alpha-fetoprotein, a protein normally made by a fetus. And LDH is lactate dehydrogenase, an enzyme found in many tissues. These markers aren't always raised, but when they are, they can help indicate the type of tumor, how much disease there is, and really importantly, track how well treatment is working later.
Any other bloods mentioned initially?
Just standard things like liver function tests and kidney function tests like creatinine, just to check overall health and see if organs are affected by advanced disease.
And imaging. What's crucial there?
A bilateral testicular ultrasound scan. Your notes describe this as the key initial imaging test. It's great at confirming the lump is actually in the testicle and helps distinguish it from other things in the scrotum.
And then for staging, to see if it's spread.
Your notes list a chest X-ray as a baseline check for lung metastases. Then, a CT scan of the abdomen and pelvis is standard to look closely at those para-aortic lymph nodes and also get a better look at the lungs. A CT or MRI of the brain isn't routine but is done if the HCG level is very high or if there are lots of lung mets, as that increases the risk of brain involvement.
And the absolute final confirmation, the definitive diagnosis.
That comes from histological assessment. Looking at the tissue under a microscope, your notes are clear. This is usually done on the testicle after it's been surgically removed, the orchidectomy. That confirms it's cancer, tells you the exact type, seminoma or which type of NSGCT, and provides info for staging systems, like the Royal Marsden one mentioned, which basically classifies how far it has spread, and that staging is what guides the treatment plan.
Right. Which brings us perfectly to management. How is testicular cancer treated, according to your notes?
Okay, the key message in your notes is that treatment is highly individualized. It really depends on the stage, how far it spread the specific type, seminoma or NSGCT, and maybe other risk factors. The main tools are surgery, radiotherapy, chemotherapy, and sometimes for very early stages, just close surveillance.
Surgery is usually the first step, though.
Yes, almost always. The standard initial treatment is the orchidectomy, removing the affected testicle. Your notes specify a radical inguinal orchidectomy, meaning they make the incision in the groin, not the scrotum, to control the blood vessels and lymphatics properly.
And after the surgery, the path depends on the findings.
Exactly. Your notes outline different scenarios. For example, for a stage I seminoma, meaning it hasn't spread beyond the testicle, the options after surgery might be active surveillance, just monitoring closely, giving 1 or 2 doses of adjuvant chemotherapy, usually carboplatin, or sometimes adjuvant radiotherapy to the abdominal lymph nodes.
What if the seminoma has already spread?
For metastatic seminoma, say stage IIA, as mentioned in the notes, it might involve both chemotherapy and radiotherapy. For more advanced spread, like stages ICD 3 or 5, the notes indicate that cisplatin-based chemotherapy becomes the main treatment.
And how about the NSGCTs?
For NSGCTs considered good prognosis, cisplatin-based chemotherapy is also standard. If it's a high-risk stage I NSGCT, your notes mention they might get the orchidectomy followed by adjuvant chemotherapy, often a combination called BEP.
BEP, what's that stand for in the notes?
bleomycin, etoposide, and cisplatin. It's a well-established, effective combination chemotherapy regimen. Your notes also mention specific treatments for carcinoma in situ, CIS, like low-dose radiotherapy or just removing the testicle, and that sometimes if there are residual lumps left after chemotherapy for NSGCTs, those might need to be surgically removed too.
Makes sense. Beyond the cancer treatment itself, what about supportive care mentioned in your notes?
Some really important points here. Offering a testicular prosthesis, an artificial testicle for cosmetic appearance after surgery, is standard. And critically, discussing and offering sperm banking before starting chemotherapy or radiotherapy is vital, because those treatments can unfortunately affect future fertility. Counseling and general support are also mentioned as key parts of care.
And after all the treatment, follow-up is key.
Absolutely crucial. Your notes stress the need for regular checkups, blood tests for those tumor markers, and scans, especially over the first 5 to 10 years. This is all about catching any possible recurrence early when it's most treatable.
So pulling it all together, what's the bottom line on prognosis from your material?
It keeps coming back to that excellent prognosis we talked about at the start. It's consistently reinforced in your notes. Especially for disease caught early, that 5-year survival rate really is over 95%.
Does it vary much between patients?
It does, yeah. Your notes confirm that the stage at diagnosis is the biggest factor. But the specific tumor type and those initial tumor marker levels also play a role in predicting outcome.
So finding it early really is the name of the game.
Absolutely. Huge difference. Your notes make it clear early detection usually means less intensive treatment is needed, which generally leads to better long-term outcomes and fewer lasting side effects.
And comparing the main types again, prognostically.
While both generally have very good outcomes, your notes suggest that NSGCTs as a group might have a slightly less favorable prognosis overall compared to seminomas. And within the NSGCTs, a rare type called choriocarcinoma is noted as having the poorest outlook.
The notes also mention public awareness campaigns. How do they fit in?
They're seen as really important. By encouraging things like testicular self-examination and prompting young men not to ignore any changes, these campaigns directly help achieve that crucial early diagnosis, which, as your notes repeatedly stress, is the key to tapping into that high cure rate.
Okay, lastly, let's cover complications. What are the potential downsides, long-term issues, either from the cancer or the treatment, according to your notes?
Right. Complications can come from both sides. The disease itself can relapse or metastasize, obviously. But the treatments, while highly effective, can also have side effects and long-term consequences.
What are the main treatment-related ones listed?
Infertility is a big one, which is why sperm banking is so important beforehand. Hormonal changes can occur, potentially low testosterone or hypogonadism, after removing a testicle, though the other one usually picks up the slack.
Your notes mention cardiovascular risks as well.
Yes, that's a significant point highlighted. Both radiotherapy to the chest or abdomen and certain chemotherapy drugs can increase the long-term risk of heart problems or stroke. Your notes even compare the level of risk to being similar to that from long-term smoking, just to emphasize it's a real, significant late effect that needs monitoring.
Any other chemo side effects mentioned?
Peripheral neuropathy, nerve damage causing numbness, tingling, sometimes pain, usually in hands and feet, and hearing loss or tinnitus are listed as potential side effects of cisplatin-based chemo.
And even further down the line, years later.
Beyond the cardiovascular stuff, there's a small but real increased risk of developing certain other types of cancer, secondary malignancies, years after completing chemotherapy. Your notes also mention that late relapses, while uncommon, occurring years after treatment, do happen occasionally and unfortunately tend not to respond as well to further chemotherapy.
And of course, the psychological impact.
Absolutely. Going through a cancer diagnosis and treatment, especially as a young man, carries significant emotional and psychological challenges. It's definitely acknowledged. But it's important to finish on the positive note that your material emphasizes. Despite all these potential hurdles, the vast majority of patients recover well and regain a normal quality of life after successful treatment.
Okay, that feels like a really comprehensive run-through of the key information packed into your notes on testicular cancer. We've covered the definition, risk factors, how it behaves, diagnosis, treatment, prognosis, and those potential complications.
Yeah, we've seen it's the most common cancer in young men, which is striking, but also, crucially, it has this incredibly high cure rate, particularly if it's picked up early.
So maybe a final thought for you, the listener, to mull over, directly stemming from this material. We heard the incidence rate seems to be increasing, yet the cure rate when caught early is fantastic. So what more could be done? How might ongoing public awareness, maybe better targeting of risk factors or early signs, push those excellent outcomes even further globally?
It's a practical question that flows right out of the data points presented in your notes, isn't it?
Absolutely. And listen, if you are revising, perhaps for the MSRA or something similar, and you want structured resources, do check out passthemsevere.com.
And for some excellent free resources, practice questions, things like that to help consolidate this kind of knowledge, definitely head over to freemsra.com.
Thank you so much for bringing this topic and these detailed notes for our deep dive today. We really hope breaking it down like this has helped make it clearer and stickier for your revision.